So Project ECHO stands for Extension for Community of Health Outcomes, and they believe in moving knowledge, not people. It was created by Dr. Sanjeev Arora over 20 years ago, and he has just recently retired this year, and they have, I think, just recently hired a new executive director. I can't think of her name. They've just brought her on board, and he started Project ECHO about 22 years ago when a mother walked into his Albuquerque, he's a physician, a mother walked into his Albuquerque office with preventable disease that could have been prevented, though she lived in very rural area and couldn't get access or transportation to care in Albuquerque. And by the time she reached his office, um, it was too late for her treatment of, was it TB, Kelly, or Hep C?
Pepsi.
Hep
Pepsi.
C.
Pepsi.
Pepsi, and a short time later she passed away. So from that experience, he felt that there was a need to create more access in rural areas, especially where disease and treatment for care can be preventable of death. So the ECHO mission really believes in making knowledge accessible at the right time and at the right place.
So one of the main things he says is that it should be free for everybody.
Mm-hmm.
And I believe it's over 100 countries around the world now and all over our country. So it's very exciting.
Yeah, and the Echo, this platform is used, it really is knowledge sharing. So it's not just a lecture, but it, really encourages a lot of participation, questions from, the audience, opportunities to submit cases, or again, for us, it's tended to be more questions, common scenarios, et cetera, so that it can, really be very interactive, like is shown on the slide. And it's a case-based learning. With some of the other echoes around the world, they really do submit cases, and it's almost like building a community of practice around a certain topic. But there's echo sessions in almost every kind of common disease category at this point. But this opportunity is one related to long COVID and chronic fatiguing illness, in part because this is newer, since COVID, and there's a lot of, as we know, COVID does exist, and there are lots of patients, still with different lasting side effects, and there's not a lot of it's well understood, but yet we have a lot of patients, right? So this is really meant to help, again, increase the knowledge around the world about long COVID and chronic fatiguing illnesses. And in this particular instance, we're here kind of with the Asia Pacific hub. So go ahead, Summer.
No, yes, thank you for that. And we'll be joining the Schmidt Initiative Long COVID global effort. So they have global hubs on long COVID and fatiguing illness around the world, and we'll be filling the gap in the Asia Pacific. And as Lee and Kelly mentioned, it is an engaging way that all teach, all learn. You can bring cases. It's a case-based model of learning where you can bring cases, specialty cases. So the knowledge is brought to the group, and they can extend as spokes out into our communities far beyond, and knowledge can really expand. And we will try our best to, if cases can't be brought, we'll have a patient perspective brought as part of the learning here. And I just wanted to give some of the ECHO numbers this year. Well, as of the 2024 annual report, over 80 million patients were impacted in over 202 participant countries. And now we have almost 7.5 million people in attendance in our ECHO sessions and 1,546 ECHO hubs and 43 super hubs. So that's a big jump from the 2024 annual report, 2,800 ECHO programs. And as of today, I just checked the website, over 8,000 programs. So that's quite substantial.
And we in Hawaii have over 100 people a week. So that's exciting right there. The thing that Dr. Aurora noticed was that he couldn't go out to every corner of New Mexico, so he couldn't save all these people with hepatitis C. So he had a core team of psychologist, social worker, internal medicine. He's a hepatologist, community health worker, I think, all at the central location, and then caretakers, providers from around the state would present the cases, and they would all learn from all the different perspectives. So we try and do that here, and it's very exciting that we're starting this long COVID. And I think they're shutting the door, so I better go.
Okay, thanks, Kelly. And Kelly and Greg here on the call, Greg Kishawa, thanks for joining us. They were our pioneers of bringing Project Echo to Hawaii. Over 10 years ago, they went down to the University of New Mexico and were able to attend the training and get the certification and the license to bring Project Echo to Hawaii. So we've been here for over 10 years now, Kelly, with Behavioral Health Echo. Thank you. I'd just like to recognize and mahalo and thank our partners, the SILC team, Project Echo at the University of New Mexico, University of Hawaii at Manoa, our JABSOM team, our AHEC, and Hawaii State Department of Health. And I keep getting stuck on these videos. We don't have to watch this video. And these are the Echo offerings we have here at Hawaii State Rural Health, with our Asian Pacific Silk Echo being the newest. We have Behavioral Health Echo, our Geri Echo, which is comprised of Care Home Echo as well, Health Equity Echo, and Pediatric Echo. There are multiple ways to present a case, and we have a formal process, but we don't like to make that a challenge to you. So by any way, if you want to present a case to us, please just reach out with a simple email, and we'd love to get your case on here for our interdisciplinary team or our participants to kind of work through, even if it's in a short email form. It doesn't have to be a clinical form. And like I had mentioned earlier, if not, we'll always try to have a patient perspective on our future sessions. Oh my goodness. And I think that's it, just a quick overview. And as always, if you have any questions, please feel free to reach out to any of us. We'll do our best to answer any questions or forward your questions to the correct people for the right answers. I'd like to introduce Dominic Chow. Mr. Dominic Chow is from Queens Medical Center. He's our long COVID clinic there.
I just wanted to thank everyone for participating. It's quite exciting for us, exciting for me, in terms of trying to get more collaborations with you all in terms of this topic of long COVID. And it's exciting. I think they first reached out to Summer and Dr. Lee Lam with SILC, which is the Schmidt Initiative for Long COVID. Some of you may know the Schmidt Initiative is from Eric Schmidt, who's one of the CEOs of Google, and he was interested in this topic because his wife's brother has long COVID, and so having inflicted on this, he was passionate about trying to help his own family, but in the process found out that we don't have all the answers to long COVID, and it's really at a beginning of this whole illness that we're all finding new and new information about this condition. And so I'm a HIV provider, as is Maya, Barney. Both of us are still part of the Hawaii Center for AIDS. And like many HIV providers, because of it being a viral illness, we pivoted from HIV care to long COVID because of SARS-CoV-2 and its infection and its impact throughout the world. And so you'll often see many of the HIV providers, also long COVID, also providers, because there's a issue of viral persistence, which I'll get into, in many of, that being the first pandemic of HIV, this being the long COVID being the second pandemic, and the impact throughout the world is quite extensive. And so with that, I'd like to welcome everyone. This will be our inaugural introduction into the SILC, Asia Pacific SILC ECHO program. Both Maya and myself have participated in the ECHO in hepatitis C. We just had both finished presenting and being part of that ECHO here in Hawaii. But this is exciting for us as this is a new endeavor for us. I am a professor of medicine and also a clinical professor of pediatrics. And as I mentioned, I'm an HIV provider by trade. So next slide.
So we're going to start with a poll really quick. I put a hyperlink into the slideshow so you can actually just click the slide and it'll take you to where the poll is, or you can use the QR code to go to the poll. But in the interim, I'm going to just read the question and the answers to you guys. So what are you hoping to get out of this ECHO series? Actually, hold on one second. Let me see if I can share. Oh man, I miss Zoom, guys. I miss Zoom. So you guys should actually be seeing the icebreaker now. So what are you hoping to get out of this ECHO series? Learn from my peers, update my workflow for long COVID patients. Nothing. Long COVID is a myth. Gain a better understanding of long COVID to better address the needs of my patients, or I'm just here for the CMEs. We'll give that a few minutes just to, well, a few seconds really. I'm going to switch back to the other screen really fast. This was more meant to just break the ice. We are really hoping that if you're tuning in here, you don't think that COVID is a myth. Let's see here.
I'm not able to get into the.
Even using the link?
I'm using the QR code.
And Nora,
Oh, you guys. Okay, I'm so sorry. I think Queens has some of these forms pretty locked down. So we'll just work around it, you guys. But anyway, what we're hoping for is that obviously like you're using this to kind of impact your practice with your patients. We know that the number of long COVID clinics or even long COVID like specialists is decreasing. And there is a lot of work that unfortunately like primary care is already doing. But there is some information that we want you guys to be able to take forward to your own practice. So we're really hoping that we're going to be able to kind of help with that. Okay.
So our objectives are to introduce the topics and themes because we will be having really some absolutely fantastic, well, nationally as internationally recognized individuals in the long COVID field. But there will be, I guess, recurrent themes which I want the audience to appreciate. One of the biggest topics is the definition of long COVID, which I'm going to briefly touch a base. And then again, some of these themes are going to come up over and over again, where I think trying to actually kind of set the stage for the audience to kind of appreciate that there are a lot of limitations because we don't know enough about long COVID. Even the mechanisms is being hotly debated. And then if you don't understand the mechanisms and the subtypes, the biomarkers that might not be there, then the treatments may also be hit or miss in regards to your clients. And so we're going to touch base on these couple issues and then talk about themes that we've encountered with long COVID patients. And then Maya will talk about some of the insights gained at our clinic. So next slide. And so just to try to start it off with the definition of long COVID, it could be a little vague and also quite broad in sense. Long COVID is also known as post COVID conditions, is an infection associated with chronic conditions that often occur with the SARS-CoV-2 infection and is at least present for 4 weeks. And then it talks about having some continuous relapsing and remitting and progressive disease states. Now, the WHO has characterized by a range of symptoms that usually starts with 3 months after initial COVID-19 illness, and that at least it lasts for 2 months. And the differences are that the WHO is more explicitly recognized as an episodic ebb and flow pattern of symptoms, and it looks at more resource limiting settings. There are other societies, such as the National Academy of Science and Engineering and Medicine, where they actually focus more on trying to classify and remove some of the false negatives and false positive classifications. And they tend to look more towards the 3 months period rather than looking at trying to further define the conditions themselves. Whereas the British National Institute of Health and Care Excellence, or NICE, includes the period right after acute COVID, 4 weeks to up to 12 weeks, and greater than 12 weeks or more. And so it tries to break down it into like post-ICU, residual sequela, post-viral guidance, long-term COVID syndromes, and then permanent organ disease. And then lastly, the American Physical Therapy Association doesn't have a formal diagnosis, but it looks at more of the physical conditions of people, the pacing, the planning, kind of like the posturing and positioning of patients and priorities in terms of how to actually get people to be more functional. And so the definitions can be quite broad, and you can see it's very heterogeneous. There's not a real pinpoint diagnosis or conditions. And so now it makes it a little broad, and therefore many conditions may be associated with many of these broad definitions that you see. So next slide. And you can see that with acute SARS-CoV, the infection being up on the upper left-hand corner, and you could see that it causes common symptoms of persistent fatigue, malaise, concentration, memory issues, and then that impacting the pathology of long COVID, where there are diagnosable conditions where you could see cognitive impairment from migraine, strokes, and mood disorders to interstitial lung disease and hypoxemia, cardiovascular disease with arrhythmias and blood clots, and then you could see down further below autonomic symptoms, which we'll probably get into later in the sessions in terms of postural orthostatic tachycardia syndrome, mast cell activation, hyperlipidemia, as well as diabetes, and then myalgic encephalomyelitis and chronic fatigue syndrome, and then you have all the rheumatologic illnesses, and then some of the common features where you could see long COVID can affect children and adults somewhat a little bit differently, or overall there are some similarities, but there are immunologically differences between the two populations. COVID can resolve rather quickly over months, or it could persist over years. And then what's important to know is that long COVID is not a diagnosis of exclusion. So it could be tricky in terms of diagnosable conditions and also trying to piece this all together. And so next slide, just for people to continually think of that there are, since there's an absence of a clear biomarker and there are overlapping other post-viral syndromes, that it could be hard to recognize and make a clean diagnosis of long COVID. And so just to know that there are like MACSF, or the chronic fatigue syndrome, that it can often cloud what we see in long COVID. And that's how come in our title for our Asia long COVID series, it is these relapsing, fatiguing illnesses. Fibromyalgia comes into mind, as well as the postural orthostatic tachycardia syndrome, or POTS. But as in infectious disease, we all know that post-Lyme syndrome, West Nile, Zika, EBV, flu, and HIV all have these long COVID-like symptoms. We probably have seen this before, but it's probably more common now since long COVID has affected such a large swath of our population. And so public perception is influenced by factors such as education and health. And so that has to be always, and then misinformation and stigma hinders accurate diagnosis and treatment. So we always have to come in, it's good to be skeptical of long COVID and trying to see if there are other diagnoses that you could actually pinpoint on your patients. So next slide.
So we have another poll, and just to kind of save ourselves some heartache, I'm gonna just put it over here on this screen. If you guys want to take a little guess, you can drop it in the chat really quick. The question is, how many people globally are estimated to have experienced or are currently experiencing long COVID? So 1 billion individuals, 100 million individuals, 950,000 individuals, 400 million individuals. So if you want to just throw it in the chat, I promise we'll work this out next time, guys. So I have 400 million. Oof, no idea. I feel you. 1 million, 400 million. So yeah, 100 million. The answer is 400 million individuals are estimated to have experienced or currently experiencing COVID. So I'll next slide myself.
So yeah, so it's estimated that 400 million individuals globally have experienced or are currently experiencing long COVID, and that the long-term manifestations of these individuals is quite profound. 6% of those individuals with long COVID will have neurologic or psychiatric conditions. 4% will have cardiovascular conditions, and 2 to 4% will have respiratory. So you're talking about large numbers of individuals that will have some breaking point in terms of burdening the overall health systems that we currently have. So, in more importantly, long COVID can have significant impact on work capacity and daily functioning. And so, you may know some of your patients or family and friends who have long COVID, and they'll tell you about how it is a struggle to actually do work capacity and then even daily functioning. And so it's really debilitating to a large number of individuals. Next slide. And so here in the United States, the 400 million is worldwide, but in terms of the public health impact in the United States, the CDC has estimated about 6.9% of adults and 1.3% of children in the United States have reported experiencing long COVID. This really translates to 17 million people and 1 million children. So quite a large number of individuals having this condition. And you can see females having more than males. And this is adults where you can see mainly it's middle-aged women who have long COVID. But in pediatrics, which we'll hear next at the next session, it's kind of flipped. It's mainly males who have higher rates of long COVID, and the conditions and presentations are quite different from adults. Next slide. Here in Hawaii, there is a health disparity, like many illnesses, where health disparity is different among race and ethnicity. You can see that people who are Native Hawaiian or Pacific Islanders, the cases of long COVID, the cases of acute COVID, as you could see on the lower, on the left-hand side, cases are higher among our patients who are non-white. And then you could see also the hospitalization is much higher, as well as the deaths. And on the far right, you could see within our long COVID clinic, you could see the breakdown. This was about 2 years ago, the initial long COVID clinic we're seeing by far large populations, over 50% of people who are Native Hawaiian and Pacific Islander and Filipino. The rest were as you see, the breakdown as you see. So we're all talking about a health disparity issue that also is occurring with long COVID. Next slide. And here's the potential mechanisms, which I think goes back to the next sessions that will be coming. You'll be hearing experts in terms of various specific specialties from neurology, cardiovascular, to renal and GI, where we think that the long COVID, if you look in the center, long COVID, if you have a full recovery, it's on to the right. But with long COVID itself, you could see that it will, perhaps there's viral persistence, which you could see in C, that leads to cytokine dysregulation, immune dysregulation, which our groups, I saw Sandy on the line in the chat in the audience, as well as Jerome Park and our group have looked at neutrophil dysregulation as well as monocytes, and you'll hear about in the coming weeks T cell dysregulation, specific T cells that may actually be the problem that's attributing to long COVID. But I don't think there's an easy mechanism. You'll be hearing about the viral persistence, about the cytokine dysregulation, the amyloid deposits in muscle and tissue, as well as some of the long COVID subtypes, which I'll get into a little bit later, and then thrombotic endotheliitis and some of the microclots that some investigators have all talked about, the fibrin issue that will be talked about further. I do want to say that post-viral transcripts is a big thing, as well as viral latency. It's becoming more and more of a accepted mechanism of long COVID, where there's ongoing viral replication or latency. People have done viral studies in tongue and nasopharyngeal biopsies, as well as colonoscopies in the sigmoid rectal joint junction, where they have recovered viral persistence in those patients. And so next slide. And so just to bring up, there are different subtypes, and going back to the definition, are all the subtypes, do they all have a similar mechanism? Probably not, probably heterogeneous in its overall effect. You can see that the 5 subtypes that were defined by NIH Recover, which University of Hawaii is one of the sites, we did break it down to fatigue, dyspnea, chest pain, palpitation, and forgetfulness is a second subtype. Fatigue, headache, and insomnia, anxiety, motivation loss, mood, and forgetfulness is a third subtype. And then hair loss, and then finally taste and smell disorders. We have grouped them primarily because we think that the mechanisms of each of them, as you can see, fatigue could be one item which is very broad, but then probably the second subtype is more dealing with a cardiovascular homeopathic system, and then the third one more of a neurologic subtype. Next slide. And this one just shows a cartoon of what we anticipate the majority of individuals. You could see that SARS-CoV-2 exposure. You could see the purple line where you'll have viral isolation for the respiratory tract will increase and go into the millions, and then resolve completely by 2 weeks. But we do know that certain populations have continual viral persistence in the nasopharyngeal, and that's why I mentioned that people have gotten tongue biopsies and nasopharyngeal biopsies, and we have continued to show viral persistence in the nasopharyngeal cavity. Some you may have heard of, people with HIV or immunocompromised conditions will have ongoing high levels of persistence. Most of the people who have long COVID do not have those high levels. And so we're talking about better techniques in trying to find virus in these areas. Next slide.
It's poll time, guys. It's poll time. Um, so we're gonna switch gears to talk about biomarkers. So just to kind of get you in that headspace, which of the following biomarkers have been most consistently associated with persistent inflammation in patients with long COVID? Cortisol, CRP, hemoglobin A1C, troponin 1, and what is a biomarker? If you guys want to drop what you think in the chat, that would be great.
Can you repeat it again? Troponin, CRP,
Yeah.
hemoglobin,
So,
A1C.
yeah. So cortisol, CRP, hemoglobin, and troponin. Okay. So it is CRP. So I'm just gonna go backwards and then, so nice job, guys. I think most of you
Yeah.
nailed that.
Very good. Yeah. So as I mentioned, viral persistence has been in the stop PASC were negative, and even from our Angus study, which we done locally, where we did blood samples, we were unable to recover virus. However, at the UCSF group, they found virus in clot biopsies, and then I did mention about nasopharyngeal and oral areas. Cortisol has not been found to be a consistent biomarker, but we do know that individuals with long COVID have low cortisol levels. Whether or not that actually translates to, what we would traditionally think of low cortisol levels, and we don't, it doesn't require hydrocortisol treatment, but consistently in the lower right-hand corner, we do know that cortisol levels have been found in the AM to be much lower compared to people who have recovered. There are higher antibody responses. You have heard probably in the news about spike protein as being possible etiology of long COVID and how that interacts with the immune process. And there are also differences in circulating myeloid in lymphocyte populations. I did mention about certain T cells. I think the T cell CD8, certain CD8 activated cells are thought to be more consistent with long COVID. And so it's for what we just heard in terms of the questionnaire, CRP has consistently been probably the most likely marker that's been elevated, reporting or suggesting a dysregulation in a cytokine response. IL-6 has been also discussed in the past, as well as D-dimers. And a lot of my clients, I'll often see a elevated IL-6, a D-dimer, and a CRP. But CRP has been overall most consistently reported as is a biomarker that has some potential, although it hasn't been consistently been found to be of use in diagnosing long COVID or the prognosis of those individuals. So next slide. And so for long COVID treatments, there really is no current standard of treatments. You may have heard individuals talk about low-dose naltrexone. There may be varying pockets of, vitamin D and all sorts of things. But as a group, in terms of randomized clinical control trials, there has not been any single agent that has been found to be a benefit for long COVID treatment. And I think the real issue is that of the mechanism. I'm hoping that very similar to the HIV story, where there were individuals similar to long COVID, where we saw autonomic dysfunction, we saw all these similar clinical pictures along with long COVID, that it is a viral illness in the very end. And by giving an antiviral, potentially we may be able to finally control long COVID. But until that day, we won't be able to. And in the upcoming sessions, there will be some sessions talking about Paxlovid and certain antivirals, and it'll be very exciting to talk about those various cases as well as various studies. But this is just to get you in training you to talk about long COVID and how hard it could be in diagnosing and then also treating patients. So currently there is no standard of care. The clinical guidelines are unavailable to capture the complexity of each case. So need for widespread clinical trials is needed. And then the treatment focus really should be in review of past medical history and chronic medical conditions to ensure that there's appropriate workup, managing specific symptoms, and improving overall health and functionality. And that's what happens in our clinic. We're really there to treat the symptoms, but not as we don't know what the underlying cause is. And so our whole clinic is based on symptom approach in helping people get to their full functional daily activities. So I think it's your mind.
It is my turn, guys. It is my turn. I have one more poll for you since I know how much you've been really enjoying this Frankenstein's monster of a polling system we have here. So looking at the symptoms, which of the following is the most commonly reported symptoms in individuals with long COVID? Hair loss, chest pain, fatigue, joint swelling, or skin rash. So again, that was hair loss, chest pain, fatigue, joint swelling, and skin rash.
Everyone's getting 100%. Yay.
Why are you're ruining my quiz? You're ruining my quiz. Yeah, so it is absolutely fatigue. Great job, guys. 100%. So let's see here. Okay. So in terms of the most common symptoms we're seeing with patients with long COVID, a lot of what we're hearing is mostly like the brain fog, that post-exertional malaise, so just really being tired, even with like emotional or mental activities, like just feeling completely taxed. Sleeping difficulties we hear about a lot, headaches, a lot of digestion problems, so a lot of issues with GI. And then there is what, going back to what Dominic was saying about, some of the pre-existing conditions are made like significantly worse with long COVID. So migraines, lung disease, autoimmune, any of the chronic kidney disease like any of those things, like they can just get worse with long COVID. So the big thing that I've focused on with our clinic has been like engaging patients into service and kind of working through what that initial feeling is and, capturing these patients and making them feel like they're going to get their needs met. So I do want to just bring up that a lot of what I hear, so you can see here, I like noted that it was all anecdotal evidence that, I've kind of collected over like the last 2 years, but then I did also find that other people have been reporting this too. So big things are like loss of sense of self or identity, that helplessness or hopelessness, like feeling like giving up or feeling that nobody cares about them. The frustration I hear probably the most, which is like feeling like they're getting gaslit. So feeling as though their medical team doesn't really believe that they're saying what they're saying. They're not given full attention for their actual symptoms. And then, it circles back to feeling really alone, not knowing, like, not in a way that's like suicidal ideation, because we do that screening as well, but, not being able to take their symptoms as they are anymore. Like, I just don't know how much longer I can go on with this. And then the thing that I do hear a lot is that there's regression. So they might be feeling better, doing better, and something will happen, and then they feel like their progress has been, undone. And so then it like goes back. It's a negative feedback loop. So then they start feeling helpless and hopeless again and isolated and feeling like their medical team is letting them down. So that's kind of what we've been experiencing. what we have learned to do was we did modify how we are engaging patients in services. And the reason why we did this was to kind of go back to what Dominic was saying about like making sure we have a really good understanding of like past medical history and family medical history and kind of those underlying conditions that patients may have. The other thing we wanted to make sure of is that, you know, as you guys know, medical right now is a mess, to say it nicely. Everybody's stretched really thin. So it's far easier for us to kind of justify like a nurse spending 90 minutes or 2 hours with a patient than it is for a physician. So how can we make the physician's life as smooth as possible, giving them like as much of the tools as they need to kind of update the treatment plan and work with the patient going forward, right? So what we have is it's called an engagement appointment. It's like generally over the phone. It usually lasts about 60 to 90 minutes with a nurse. Once we get all of that information, and I'll show you on the next slide, like what that information entails. We also have a protocol for putting in a referral to PT and OT. And then we have like an initial lab set that we've been, again, another protocol. And then we schedule that office visit with the physician. And the beautiful thing about this engagement process is that really when the patients arrive, it's not revisiting all of the trauma and all of feeling like they've been gaslit. It's really working forward. Like, what are your goals? Like, this is what we want to work on, and getting into that symptom-based approach. So this has a lot of stuff on it. So not trying to stress you out, but the big things with it is that so we have a section of the engagement appointment that is focused on like their COVID timeline. Like what happened when you got COVID? When was it? Have you had recurrent episodes? Was this the only one? We did the normal things like reviewing the food and drug.
I think Maya, um,
I think we might have lost her. I
uh,
can display your slides.
did you?
Um,
Oh,
Yes.
you're back.
oh, I'm back. What did you guys
Okay.
last hear? I'm sorry.
The beginning, right at the initial assessment.
Okay. So initial assessment, COVID timeline, right? Making sure we understand like what's happening with COVID, what their experiences were, how sick they got, were they ever intubated? Doing the standard like food and drug allergies, reviewing current medications. So again, like those time-saving things that we're taking away from the physician plate. And then going through their past medical history. I recently had a case, for instance, where the patient, he was having a lot of breathing issues, and he had a history of like working on a farm and getting exposed to like toxic chemicals as a kid. So like knowing that history going into this, like how does that play a role? I don't know exactly, but I feel like getting exposed to something that was toxic for 19 years probably isn't really helpful when we have this like inflammatory disease, right? Um, Looking at like surgeries, family history, doing like the social histories. So again, like there is that huge push for like social determinants of health, tobacco, alcohol, making sure that we're not just meeting those standards for like insurance and quality care things, but also really making sure we understand like how many pack years do they have? Like is that playing a role in their shortness of breath? Fall risk, frailty, depression. And because I'm doing like the RNs, this assessment is all happening ahead of time, it takes off the plate of not just like the physicians, obviously, but then also the MAs. So the MAs have less stuff to do in person. Those visits can be like a lot more focused. As I was alluding to earlier, we also place like lab orders, PT and OT orders. These were like our protocol lab orders. So you can see like everybody got like this baseline. And then if they were complaining about like these main symptoms, so fatigue or muscle pain and weakness, or they had that loss of taste and smell or that brain fog confusion, we added in some additional ones. And, like I reviewed all of that with the patients in real time, making sure that they understood like what we were doing and kind of why we were doing it. We were lucky enough to have a really great team at our outpatient PT and OT group at Queens. And they worked with us to develop like a protocol of assessments that they would do for our patients. So they would observe them for obvious deficits, do MOCA, they would do the 6-minute walking test, but also the speed test, doing a balance assessment, the NASA lean test, and grip strength. So when the patients would show up for their appointments, they would have not only the expertise of like the PT, OT in hand, like these were the summaries, these are the recommendations that PT and OT is making, but they would also have all the lab work, and then they would also have my assessment. So they had everything they needed to really like plan the care rather than going back and talking about all the old things. So again, just to summarize and conclude, definitions of long COVID continue to be equivocal. They're legitimately all over the place. Like he mentioned several different possible definitions, but if you like Google it, like almost every single professional organization has something to say about it, and none of them line up exactly. There are no obvious biomarkers that can lead to diagnosis or aid in the prognosis of long COVID. Long COVID symptoms are too varied to be explained by a single mechanism. And then the treatment approaches for long COVID remain non-standardized due to how it presents and also like the past history that people have. So because of our history working with HIV, I find long COVID to be pretty intriguing because it would be so wonderful just to be like, yep, we're putting you on this one medication. It'll take care of everything. We'll get these updated labs. Like you'll be fine. Like we'll continue to monitor X, Y, and Z. There is nothing like that right now. So making sure that like the rest of our community is pretty aware of what they could do to better support patients, I think is really important because we have a long way to go, you guys, to like try to figure this out. All right. So I'm gonna stop sharing.
And just to emphasize, Maya has through her work has found patients to sometimes be inadequately worked up and treated for other conditions, and so oftentimes like asthma or COPD, in those individuals will think that they have long COVID when in fact they have conditions that that have standard treatments, and when we refer them back, they get the treatments that they truly need and are treated. So it's not always long COVID. So I think we'll open it up to anyone who has any questions regarding just this introduction into the foray of the upcoming weeks. And again, there will be some well-recognized, nationally experts in long COVID that will be passing through. And we're hoping, Lee and I thought that the best thing to do is have the national expert talk, and then we could have our own, I could provide a five slide or 5-minute experience of the local experience that we could kind of augment what is seen nationally and what we're seeing locally in our own neighborhood.
I do want to be really cognizant of everybody's time because I know our session ends in about 4 minutes. So Summer, I'm sorry if I was stepping on your toes with that announcement. But if anybody has any quick questions or concerns, unmute or drop it in the chat.
Yeah, no problem. Please, anyone have any questions or comments for Maya or Dominic, please feel free to unmute yourself or drop it in the chat. Next session will be on June 24th, and we'll be discussing pediatric long COVID echo with Dr. Peter Rowe and Dr. Jessica Kosut. And if there are no questions, mahalo both of you. And where should referrals for long COVID be sent to? We have a question in the chat.
Um, so, um, at this point, there aren't a lot of options for long COVID groups or workups anymore, especially like in the state, but also in the Pacific. So part of the reason why Dominic and I felt really passionate about like supporting this ECHO was because we wanted to make sure the community at large had kind of the tools in their toolbox to approach it. So I think instead of looking for like where to send referrals, I would definitely recommend like instituting some of these workups into your practice and working on treating the symptoms versus trying to just refer them out because the resources that we have are, you know, going away. So sorry.
Thanks, Maya. Any other questions or comments? And also, if you have any ideas of topics you'd like to discuss, please bring them to us. We're still trying to solidify our schedule of topics. But if not, thank you for a great first session. I know we'll get through all the bumps. It was our first test run. So thank you all for being here. Mahalo, everyone, and see you next week.